November 1943, Camp Forrest, Tennessee. The white gauze bandage stood in stark contrast to Oberfeldwebel Werner Müller's tanned skin as the American doctor carefully dressed the infected shrapnel wound on his thigh. After 18 months commanding a machine gun crew across the sun-baked deserts of North Africa, subsisting on dwindling medical supplies and field dressings reused until they disintegrated, this pristine field hospital with its gleaming instruments, abundant medications, and pressed white linens represented impossibility made real. The penicillin coursing through his veins, the same miracle drug administered to wounded American soldiers, cost more per dose than he had earned monthly as a civilian metalworker in Stuttgart. Across American prison camps that autumn, 371,683 German POWs would confront a reality that contradicted everything. Goebbels' propaganda had taught them about American medical inferiority. They discovered a nation where antibiotics were routine treatments, where vitamin supplements were standard preventative care, where dental services were so common that American soldiers complained about mandatory checkups. These simple medical provisions, treatments that most German soldiers had never received, would systematically demolish Nazi health propaganda more effectively than any re-education program. The mathematics of medical abundance were being calculated in sulfur drugs and surgical instruments, in vitamins and vaccines, revealing an American pharmaceutical capacity that rendered German medical deprivation not noble sacrifice, but unnecessary suffering. What began as amazement at American medical protocols would evolve into complete conceptual transformation. The desert's toll. The Afrika Korps surrender in Tunisia during May 1943 brought approximately 250,000 German and Italian soldiers into Allied captivity. These veteran desert fighters who had pushed the British back to Egypt under Rommel's leadership expected minimal treatment as prisoners. Nazi propaganda had prepared them for American medical neglect and pharmaceutical shortages. Instead, within hours of surrender, they underwent comprehensive medical screening. Military medical records show 37% of Afrika Korps prisoners suffered from nutritional deficiencies. 24% carried intestinal parasites. 18% had untreated shrapnel wounds. American field hospitals, established within collection centers, immediately administered treatments. Wehrmacht medical officers had carefully rationed or completely lacked sulfonamide antibiotics for infections, vitamin supplements for deficiencies, and surgical interventions for wounds German field doctors had deemed minor. The systematic treatment of enemies with superior medical resources began immediately, though its psychological impact would only be understood later. A German medical officer later testified to the International Red Cross, "We expected to receive only emergency care as prisoners. Instead, the Americans treated routine conditions we had been forced to ignore." This confusion about American medical resources began our re-education. The Red Cross report documented complete dental examinations for 97% of incoming prisoners, with 64% receiving treatment German military dentists would have considered non-essential. The Liberty ships carrying POWs across the Atlantic in summer 1943 provided intensive education in American medical standards. These vessels, mass-produced at unprecedented rates, transported up to 30,000 prisoners monthly to the United States. Naval medical records show that prisoner healthcare aboard these ships matched or exceeded standard crew provisions, with each vessel carrying a medical complement of 4 physicians, 12 corpsmen, and supplies calculated for 30-day treatment of the full prisoner contingent. The ship's medical bays, standard equipment on American vessels, maintained surgical capabilities throughout the 2-week crossing. Most remarkably, documented accounts confirm that blood plasma, a resource so precious that German field hospitals reserved it exclusively for officers, was administered to 247 German prisoners during Atlantic crossings in 1943. The USS General William Mitchell's medical log from August 1943 records treating a German sergeant with 3 units of plasma after hemorrhaging from an untreated duodenal ulcer, a condition that would have been considered non-critical in Wehrmacht triage protocols. When ships docked at ports like Norfolk and Newport News, German POWs encountered an America that Nazi medical authorities had declared impossible. The Norfolk Naval Hospital, with its 3,200 beds and 122 specialized treatment departments, handled more patients daily than major German military hospitals managed weekly. At port processing centers, prisoners underwent additional screening using diagnostic equipment, mobile X-ray units, electrocardiographs, laboratory testing that German military medicine reserved for highest priority cases. Military processing records from 1943 show these examinations identified 14,783 cases requiring immediate intervention, dental infections, incipient tuberculosis, untreated fractures, conditions German military medicine had classified as tolerable during wartime. The journey inland by train provided further education. Unlike the crowded, unsanitary transports used in Europe, German POWs traveled in vehicles with assigned medical personnel and emergency equipment. Documented records from July 1943 show medical orderlies assigned to each prisoner transport, with supplies for wound care, pain management, and emergency treatment. The prison camp system constructed across America housed POWs in medical conditions that exceeded Geneva Convention requirements. Camp Forrest, Tennessee, typical of the larger facilities, included a 150-bed hospital, dental clinic, isolation ward, physical therapy department, and pharmacy. According to Army Medical Corps records, each major camp received pharmaceutical allocations exceeding those of equivalent-sized German military installations, 79 different medications compared to the 46 available to German field hospitals by 1943. Oberfeldwebel Müller watched as the American doctor consulted his chart, casually prescribing additional antibiotics and vitamin supplements. The doctor explained that a follow-up X-ray would ensure proper healing, diagnostic confirmation for a condition that would have received only cursory examination in Rommel's overstretched medical units. This casual deployment of resources, medications for prevention rather than just crisis, diagnostic tests as routine rather than exceptional, demonstrated medical priorities Germans couldn't comprehend after years of increasing shortages. "Your leg should heal completely," the American doctor informed him in accented German. "We'll schedule physical therapy next week." The concept of rehabilitation for a non-officer, the allocation of therapeutic resources for full recovery rather than mere survival, represented a medical philosophy utterly foreign to Wehrmacht experience. As Müller was wheeled back to the recovery ward, past gleaming corridors stocked with medical supplies, he faced a troubling realization: he would receive better medical care as an American prisoner than he had as a German soldier. The medical infrastructure supporting prisoner care impressed even German physicians captured alongside their units. Camp hospitals represented standardized construction that challenged German assumptions about American organizational capacity. The typical facility, according to War Department Medical Corps specifications issued in March 1943, featured concrete foundation, proper insulation, steam heating, ventilation systems, and medical-grade lighting identical to stateside military hospitals. The standard 150-bed POW hospital contained operating theaters equipped with Scanlan Morris surgical lights, Castle sterilizers, and complete anesthesia delivery systems, equipment German military surgeons had seen only in premier university hospitals before the war. Stabsarzt Medical Captain Klaus Weber, formerly attached to the 15th Panzer Division, received permission to observe surgical procedures at Camp Papago Park, Arizona. His handwritten assessment, preserved in military archives, reveals professional admiration. "The American operating theater contains instrumentation we reserved for university clinics in Germany. Their standard thoracic sets include 76 separate instruments compared to our field surgery kits of 42. Most notably, their anesthesia apparatus delivers precise mixtures of gases we cannot achieve with our equipment. Each operating room maintains independent electrical systems, oxygen supply, and suction apparatus, redundancies we considered luxurious even in peacetime." The War Department's Medical Corps established a dedicated prisoner care network exceeding Geneva Convention requirements by substantial margins. Statistical records from April 1944 show one physician assigned per 387 prisoners, compared to the Convention's 1/500 minimum requirement. Each major camp hospital maintained fully equipped laboratory services with diagnostic capabilities many German regional hospitals lacked by 1943. Facilities routinely performed complete blood counts, urinalysis, bacteriological cultures, and serological testing. Diagnostic procedures German military medicine had increasingly reserved for officers and specialized units as the war progressed. In sharp contrast, Wehrmacht medical services deteriorated steadily throughout the conflict. Hauptmann Werner Müller, a medical administrator captured in Sicily, described the difference in a 1944 interview with Army intelligence. By early 1943, our field hospitals operated with approximately 63% of recommended pharmaceutical supplies. We compensated through strict triage, limiting treatments to those who could quickly return to duty. I was astonished to discover American camps provide full treatment protocols regardless of condition severity or recovery timeline. Their pharmacy stocks exceed our pre-war standards, not just in quantity, but in pharmaceutical diversity. Medical equipment allocations revealed American material abundance that contradicted Nazi leadership claims. Camp hospital inventories from 1944 documented full diagnostic suites including X-ray machines, Kelliket K42 units, electrocardiographs, fluoroscopes, laboratory microscopes, centrifuges, and sterilization equipment. These resources, restricted to major military hospitals in Germany, were standard in POW facilities throughout the American system. Camp Carson, Colorado maintained 3 complete dental operatories equipped with Ritter dental chairs, compressed air delivery, overhead lighting, and complete instrumentation sets, 1 dentist per 1,200 prisoners, compared to the estimated 1 per 7,500 in the active Wehrmacht. The operational procedures revealed American medical efficiency that defied Nazi propaganda about democratic waste. Most camps incorporated German medical personnel into treatment teams, allowing captured doctors, dentists, and medical orderlies to treat their countrymen under American supervision. This pragmatic approach reduced language barriers while providing German medical officers unprecedented exposure to American clinical practices. Medical Corps records from Camp Breckenridge, Kentucky show 17 German physicians working alongside 8 American doctors, treating approximately 3,000 prisoners while maintaining higher recovery rates than comparable German military hospitals had achieved in North Africa. Pharmaceutical supplies in American prison camps delivered particularly powerful psychological impact. In Germany, critical medications were strictly rationed. Wehrmacht field hospitals received approximately 37% of requested antibiotic supplies during the final African campaign. In American camps, medical records show full pharmaceutical formularies: sulfanilamide, sulfathiazole, sulfadiazine, penicillin, beginning in late 1943, morphine, codeine, quinacrine, atabrine, and vitamins. Camp Papago Park's pharmacy maintained 126 different medications compared to the 58 available to equivalent German field hospitals by 1943. The systematic availability of these drugs, without the triage restrictions German doctors had implemented, demonstrated pharmaceutical production capacity that rendered German shortages not inevitable. Wartime sacrifice but unnecessary suffering. Medical equipment maintenance revealed another stark contrast. German military facilities increasingly cannibalized damaged equipment to maintain essential services as the war progressed. American camp hospitals received regular maintenance and replacement through standard supply channels. Technical reports show Camp Forrest receiving 2 replacement X-ray tubes, a new operating table, and complete laboratory equipment upgrades between September 1943 and March 1944. Routine replacements that German medical officers noted would have required ministerial approval in their system. Diagnostic capabilities particularly impressed prisoners with medical knowledge. Feldwebel Hans Schmidt, a laboratory technician in civilian life, wrote in camp records, "The American mobile laboratory can perform tests we abandoned early in the Russian campaign: blood chemistry panels, bacterial cultures with sensitivity testing, serological assays. Their standard procedure for wound infections includes culture and antibiotic sensitivity testing, protocols we maintained only for general officers by 1943. Most remarkably, these resources deploy for routine cases, not just critical patients." Preventative care concepts represented the most fundamental philosophical difference. Wehrmacht medical services increasingly focused on returning men to combat, narrowing treatment to immediate battle injuries. American camp medical services maintained comprehensive health programs, monthly screening for tuberculosis, regular dental examinations, vitamin supplementation, and preventative vaccination. Medical records from Camp Shelby, Mississippi document 2,764 prisoners receiving diphtheria immunization, 3,112 receiving typhoid boosters, and 2,944 receiving tetanus vaccination during the first 6 months of operation. Preventative measures German military medicine had largely abandoned by 1942. By mid-1944, the American prison camp medical system had achieved remarkable standardization. Each major facility maintained pharmaceutical inventories exceeding 120 different medications. Surgical capabilities included general, orthopedic, thoracic, and specialized procedures. Laboratory services performed approximately 30 different diagnostic tests. Dental services provided both emergency and restorative care. This comprehensive system cost the War Department approximately $187.45 per prisoner annually, less than 4% of total incarceration expenses, yet delivering care exceeding German military medical standards at their pre-war peak. The psychological impact remained most significant. Staff Sergeant Carl Müller, assigned to medical orderly duties at Camp Swift, Texas, noted in a censored letter home, "What distresses me most is not that Americans treat us well. It is the realization that our own army could not provide equivalent care to its soldiers. Their system delivers medicine without regard to rank or recovery potential. They have somehow achieved the medical abundance we were told was impossible during wartime." This growing recognition that German deprivation stemmed from systemic failures rather than necessary wartime sacrifice began undermining the ideological foundations of Nazi authority. The medical treatments German prisoners received often seemed like miracles after years of battlefield shortages. At Camp McCain, Mississippi, 29-year-old Feldwebel Ernst Hoffmann watched in disbelief as an American dentist prepared a local anesthetic for a routine cavity filling. In the Wehrmacht, such pain relief had been reserved for officers by 1942, with enlisted men enduring dental procedures with only brief alcohol rinses for comfort. The American dentist explained that Novocaine was standard for all patients regardless of rank, a concept so foreign that Hoffmann initially suspected mistranslation. His dental chart, preserved in camp records, shows 7 cavity restorations, 1 extraction, and a full cleaning during his first 3 months in captivity. More dental care than he had received in 6 years of military service. Surgical interventions demonstrated even more dramatic contrasts. Camp Shelby's hospital performed 237 appendectomies on German prisoners during 1944, with a 99.6% survival rate and average hospital stay of 14 days including recovery. Wehrmacht medical records from the same period show field hospitals attempting to treat appendicitis non-surgically when possible, reserving operations for advanced cases due to limited surgical resources. The resulting mortality rate of 18% for military appendicitis cases represented accepted triage reality in German medical planning, but appeared negligent to prisoners experiencing American standards. Common medications taken for granted in American camps had become precious commodities in German field hospitals. Sulfanilamide, the primary infection treatment before penicillin, was prescribed at Camp Breckenridge for conditions as minor as infected blisters. 88,000 tablets dispensed during the first quarter of 1944, according to pharmacy records. By comparison, a captured German field hospital inventory from Tunisia showed monthly allocation of 7,500 tablets for a similar patient population. This tenfold difference wasn't due to manufacturing capacity. German pharmaceutical firms had pioneered sulfur drugs, but reflected American production abundance versus German strategic shortages. Penicillin's arrival in prison camp hospitals during late 1943 created particular sensation. The antibiotic, still so rare that American civilian hospitals had limited access, became available to German prisoners months before most German physicians had even seen clinical results. Medical logs from Fort Robinson, Nebraska show 17 German POWs receiving penicillin treatment in December 1943 for conditions ranging from pneumonia to wound infections, each course requiring 32 injections over 4 days, totaling 100,000 Oxford units per patient. Each full treatment represented more than an entire Wehrmacht field hospital might receive monthly during the same period. Nutritional interventions revealed systematic differences in medical philosophy. American camp dietitians prescribed special meals for 26 different medical conditions, from diabetes to ulcers, with appropriate caloric and nutrient modifications. These therapeutic diets included eggs, dairy, and fresh produce, even during wartime rationing. Camp Forrest's medical mess served approximately 380 special diet meals daily by mid-1944. In contrast, German military hospitals had standardized all-patient diets by 1942, with only critically ill officers receiving nutritional modifications due to supply constraints. Surgical equipment quality particularly impressed German medical personnel. Oberarzt Friedrich Weber, a thoracic surgeon captured in Tunisia, received permission to observe chest operations at Camp Chaffee, Arkansas. His report, submitted to the camp commander, notes the American thoracic instruments are finer and more precisely manufactured than our best sets. Their surgical lighting permits shadow-free deep cavity visualization we cannot achieve with our equipment. Most remarkably, they maintain sterile field protocols we abandoned as too resource-intensive by 1942. These observations, shared among German medical officers, systematically undermined confidence in Reich's healthcare priorities. Rehabilitation services represented the most philosophical contrast between systems. By 1943, Wehrmacht medicine focused almost exclusively on returning men to combat or discharging those requiring extended recovery. American camp hospitals maintained dedicated physical therapy departments, occupational therapy programs, and convalescent services, resources German military medicine had largely abandoned. Camp Barkley, Texas provided 2,783 physical therapy sessions to prisoners during 1944, employing hydrotherapy, electrotherapy, massage, and therapeutic exercise treatments. German hospitals increasingly reserved for officer rehabilitation. Optical services delivered everyday care that had become luxury in Germany. Each major camp maintained basic optometric capabilities, with regional facilities providing manufacturing services. During 1944, approximately 28,000 German prisoners received prescription eyeglasses through this system, custom-ground lenses in standard frames provided at government expense. A captured Wehrmacht medical directive from January 1943 had limited military eyeglass replacement to combat essential personnel, with others placed on indefinite waiting lists due to materials shortages. Disease prevention measures showed striking statistical success. Tuberculosis screening, conducted monthly through mobile X-ray units and skin testing, identified 4,112 cases among the prisoner population during 1943–45. These patients received isolation, appropriate nutrition, and treatment protocols identical to American military personnel. The resulting recovery rate of 61% for moderate cases significantly exceeded contemporary German military outcomes of approximately 40%. The systematic application of preventative screening, early intervention, and complete treatment protocols, rather than waiting for symptomatic disease, demonstrated fundamental differences in medical approach. Laboratory diagnostic capabilities revealed technological gaps that shocked German medical personnel. Standard American camp hospitals maintained equipment for complete blood counts, urinalysis, bacteriology, chemistry panels, and parasitology. Laboratory logs from Camp Breckenridge show approximately 18,000 diagnostic tests performed monthly on a prisoner population of 3,000, a rate of testing German military facilities couldn't approach. Feldwebel Kurt Schmidt, a laboratory technician in civilian life, noted in a camp memoir, "The Americans test first and diagnose second. In our final field hospitals, we diagnosed clinically and reserved laboratory confirmation for unusual or critical cases only. The most compelling evidence came from prisoners' own bodies." Medical examination records show average weight gain of 12.4 pounds during the first 6 months of captivity, despite normal activity levels. Dental records document average 3.8 carious lesion repairs per prisoner during the same period. Physical fitness evaluations show measurable cardiovascular improvement, muscle strength increases, and resolution of minor nutritional deficiencies. These physiological changes, visible and undeniable, provided living proof of the superior resources available in American medicine. By 1945, approximately 371,000 German prisoners had received medical care within the American camp system. These men had collectively experienced 126,700 dental procedures, 31,450 surgical interventions, 18,300 diagnostic X-rays, and more than 2.6 million outpatient clinic visits. The comprehensive nature of this care, systematic, standardized, and abundant, contradicted everything Nazi propaganda had claimed about American medical capabilities. Through direct bodily experience, more convincing than any argument, these prisoners discovered that American medicine delivered better outcomes, not through superior knowledge, but through systematic application of resources their own leadership had claimed were impossible during wartime. Beyond physical treatments, American prison camps provided psychological care services German military medicine had largely abandoned by 1942. The War Department's Neuropsychiatric Division established formal mental health protocols for prisoners displaying combat fatigue, depression, anxiety, or psychosomatic conditions, disorders the Wehrmacht increasingly classified as discipline rather than medical problems. Camp Chaffee, Arkansas, maintained a dedicated 40-bed psychiatric ward staffed by 2 psychiatrists and 6 psychiatric nurses, a resource allocation unthinkable in German military planning. Medical records show 3,761 German prisoners receiving psychological evaluations during 1944, with 872 undergoing extended treatment for conditions ranging from combat neurosis to situational depression. Dr. Martin Hoffmann, a German neurologist captured in Tunisia, received permission to observe American psychiatric protocols at Camp Butner, North Carolina. His professional assessment, preserved in military archives, reflects astonishment. The Americans classify combat exhaustion as medical rather than disciplinary. Their treatment, rest supportive therapy, graduated return to activity, achieves 73% return to function without punitive measures. Their systematic approach applies psychiatric principles we advocated before war economics forced more primitive management. This medical reframing of conditions German military discipline, increasingly addressed through courts-martial, represented fundamental philosophical divergence. Recreational therapy programs implemented psychological recovery methods German military medicine had theorized but rarely implemented. Fort Robinson, Nebraska established therapeutic sports programs, occupational workshops, and creative arts activities supervised by trained recreational therapists. Participation records show approximately 1,750 prisoners engaged in therapeutic recreation during 1944, with measurable improvements in depression scores, socialization metrics, and reduced psychosomatic complaints. The systematic application of these programs, standard in American military recovery protocols, contrasted with Germany's increasingly utilitarian approach to psychological casualties. Nutritional education programs integrated preventative medicine concepts increasingly absent from German practice. Camp dietitians provided formal instruction on balanced nutrition, vitamin functions, and dietary disease prevention. Camp Barkley, Texas conducted a 12-week nutrition education program attended by 2,187 prisoners, documenting improved health knowledge through pre- and post-testing. Similar programs operated in 73 major camps by 1945, representing systematic investment in preventative health knowledge transfer rather than merely treating existing conditions. Medical research access for German POW physicians revealed scientific isolation caused by Nazi policies. American medical officers routinely shared current journals, textbooks, and research papers with German counterparts, documenting medical advances unavailable in Germany after 1941. Camp Forrest's medical library contained 342 medical volumes and subscriptions to 17 medical journals, including JAMA, the New England Journal of Medicine, and specialized publications. German physicians, initially skeptical of American medical research quality, documented growing recognition of scientific advances developed during their isolation. Dr. Klaus Weber, captured in North Africa, noted in a letter passed by censors, "I have discovered American medicine has advanced beyond our knowledge in several critical fields. Their trauma management, infectious disease protocols, and antibiotic developments exceed our current practice. The scientific isolation imposed by our authorities now appears a critical strategic error." Language acquisition through medical interactions created unexpected educational benefits. German POWs working as hospital orderlies, laboratory assistants, and medical clerks developed specialized English vocabulary through daily clinical exposure. Camp Shelby documented 127 German prisoners achieving functional medical English within 6 months of hospital assignment. These language skills, technical, precise, and professionally valuable, represented transferable knowledge beyond their immediate utility. Former Wehrmacht medic Werner Müller recorded in his diary, "I have learned more practical medical terminology in 3 months of hospital work than in 2 years of English instruction in Germany. This knowledge has value beyond captivity." Health improvements through systematic care demonstrated American medical effectiveness through undeniable physical evidence. Quarterly physical examinations documented progressive health markers among the prisoner population, average weight normalization, dental health improvement, resolution of minor nutritional deficiencies, and reduced incidence of communicable disease. These measurable metrics, standardized across the camp system, provided statistical proof of superior outcomes. Camp Carson, Colorado, documented average hemoglobin increases from 13.2 Gzl at capture to 14.7 Gzl after 6 months captivity, objective evidence of nutritional improvement under American care. The contrast between medical systems became statistically undeniable as the war progressed. By late 1944, comprehensive medical data allowed direct outcome comparisons between American and German military medicine.